Our project is designing an implant to correct hammertoes. I'm Taryn.
I'm Allison.
I'm Julia.
And I'm Nathan.
So the current clinical need for hammertoes is that 7 million people currently suffer from this deformity. The deformity is a forefoot deformity caused by a musculature imbalance that causes a curling of the toe at the VPII joint, as can be seen on the left. This deformity causes pain and calluses and is common in women over the age of 55. The current industry is a $1 billion per year industry, and there are about 550,000 procedures each year. 17% of patients are unhappy with the results of this procedure because of postoperative pain and recurrence that may happen as seen in the right. The current gold standard for the treatment of this deformity is the Kirschner wire, which uses an arthrodesis PIP procedure, which is the removal of the bone from each side of the PIP joint, and then the insertion of a 4-inch stainless steel wire through the end of the toe, as can be seen in the image on the right, and the x-ray of this wire can be seen in the image on the left. Some limitations of this procedure are that it's percutaneous and infection is very common, occurring about 18% of the time. The wire can break or loosen. The full recovery takes about 3 to 6 months, and the recurrence is common, occurring about 47.8% of the time.
So our approach to solving this problem is to be using a one-piece titanium implant for fixation of the bone at the PIP joint. So this implant is going to be fabricated using Ti-64 titanium alloy, and it's going to be fabricated using selective laser sintering to create 200 to 400 micrometer sized pores in order to maximize osteocyte ingrowth. In addition to this, it's going to have protrusions, ridges, and holes in multiple planes in order to further increase the surface area in contact with the bone and thus improve anchorage. Once the device is fabricated, we're going to include a hydroxyapatite coating applied using pulse laser deposition, and the hydroxyapatite is going to further increase the osteocyte activity as well as osteoblast adhesion. Finally, the implant is going to be inserted using the same surgical procedure, the PIP arthrodesis, which is used by surgeons to insert the K-wires. In this case, it's going to be a familiar procedure to the surgeons and is not going to require any changes on their part.
So our implant has a lot of benefits over the current gold standard of K-wires. Because of the size of the pore and the hydroxyapatite coating, it will be osteoconductive, which will promote bone fusion. K-wires have a very low rate of complete bone fusion, but we hope with our implant to have greater than 90% of patients have complete bone fusion, which will help them have a shorter recovery time so they'll be able to put weight on their foot faster and get back to normal activities. Because it is completely internal and not percutaneous, there will be less complications such as infections as seen in K-wires, and because of the bone fusion, there will be less reoccurrence than K-wires. In addition, patients who have K-wire surgeries report pain up to 6 months after surgery, where we hope because of the fixation of our device, there'll be no pain within a week post-operation. There are some costs to our implant because it's made of titanium and has a lot of small ridges and protrusions. It will be difficult to machine. The implant does remain in the toe for the entire lifetime of the patient, so it can have some unpredictable consequences, such as the vanadium in the alloy could release cytotoxic ions, and the coating is brittle, so breakage is a concern.
So some of the competition in this field are the K-wires, which are the current gold standard, as mentioned before. These are low cost and familiar to surgeons because they are most commonly used, but they do cause percutaneous infection, extra discomfort for the patient, reoccurrence of the hammertoe deformity, and have multiple surgical sites, so they have multiple wounds to heal. Additionally, there are other titanium implants on the market. Most of these implants are two-piece implants and can often be cannulated for use with the K-wires. They also have a tendency to loosen or rotate and cause movement between the two pieces, which causes complications for the patient. And finally, there are shape memory implants, which are made from nitinol. These shape memory implants are available in limited sizes and are slightly inconvenient because they have to be frozen for 2 hours before insertion in the foot, and they cannot be changed in shape or orientation after the shape change has taken place.